We currently have 2 approved combination therapies for BRAF-mutant melanoma. We have Dabrafenib and Trametinib, and we have Vemurafenib and Cobimetinib, BRAF and MEK inhibitor. These are now approved therapies, they're standard of care. So what's new in this space as we go forward? Well, we're starting to understand about subsets of patients that may do better or worse with the approach of dual targeting of BRAF and MEK in the patient's tumours. So what we're learning is that patients, particularly with an elevated lactate dehydrogenase, have poor progression-free survival and overall survival. And to me, this is very important data because we're starting now to select a patient population that is not going to do well and where we need to think about alternative therapies to get long-term disease control. So in addition to the lactate dehydrogenase, there are additional markers as well. The number of metastatic sites or the presence of liver metastases is predictive of poor outcome. And interestingly, performance status. It keeps coming up that there is a distinct difference between a patient who has an ECOG performance status of 0 and a patient that has an ECOG performance status of 1. 1 meaning there are symptoms, of course, related to the disease. So in that setting, if the lactate dehydrogenase is high, there's involvement of multiple visceral sites or the liver, these patients do very poorly with the targeted therapies, and we need to innovate. Maybe combination CTLA-4 PD-1 is the way to go at the moment for those patients, but we await with great anticipation this similar analysis of dividing up the metastatic melanoma into subsets for the immune therapies as well as the targeted therapies to start to identify these subsets of patients and optimise the choice for each individual patient as to the best therapy.